In the third session of the Ohio State University Nice-Unger Center Echo on evidence-based psychotherapy for adults with intellectual and developmental disabilities, we'll be hearing from Dr. Katie Walton, Associate Professor of Psychology and Psychiatry, Director of Research and Program Director of Nice-Unger's Early Learning Program. She'll be sharing some information about assessment tools and practices in serving this population. Our learning objectives today, we would like you to leave with some understanding of the role of assessment in person-centered therapy, be able to identify validated and adapted assessment tools, incorporate client self-report and support person input, adapt assessment methods for cognitive communication, and to use data to guide collaborative goal setting and treatment planning. At this time, like to invite Dr. Katie Walton to the stage to share her slides and take it away. Welcome, Dr. Walton. Thank you for being here.
Sorry, trying to get everything toggled so I can see some of you and see my slides and everything at the same time here. Um,
No worries.
anyway,
That's always the trick. And again, I'll invite everybody to think about as we're hearing this great information, think about any questions that are popping up for you and add those in the chat. We'll have some time to ask Dr. Walton some questions here towards the end. Thanks again.
Absolutely. So I'm excited to talk with you all about assessment tools and practices for adults with intellectual disabilities. And I know that, we're talking about psychotherapy here and adaptations to psychotherapy. So I think kind of the first question that people might have to ask is, well, we're talking about therapy, we're not talking about assessment. Why do we need to spend time on assessment here? So that's really where I want to start with thinking about assessment and what role does assessment have to play in psychotherapy? Because I think oftentimes when we think about assessment, what jumps to mind is sort of diagnostic assessment of, for example, intellectual disability or autism or some other developmental disorder. But when I think about assessment within psychotherapy, we're thinking more about assessing things like what are the mental health symptoms and needs that the person might have, as well as things around what might be their communication needs, adaptations they might need to therapy, things that are going on in their environment that might be informing what brings them to psychotherapy and the things that we might work on in psychotherapy. So I really want to spend a few minutes starting by talking about why is assessment important? What are we expecting that to do for us in the course of psychotherapy with a client with intellectual disability? Or really, I think this applies to pretty much any client. So I think the things that jump to mind first when we think about intake assessment, for example, are those practical purposes. Most people who have done therapy know that we have to do some sort of an intake to do things like determine what diagnosis or billing code we're going to put on our authorization paperwork, maybe thinking about what services the person is eligible for, either within our organization or in other organizations where we might make referrals. And that is certainly an important purpose of doing that initial intake assessment. But I would argue from a therapeutic perspective that it's actually the least important purpose of assessment when we think about moving forward into doing effective therapy for a client. So I want to spend a little bit more time on the other two pieces here. So one is certainly treatment planning. We need to understand what diagnosis or diagnoses might match for a person. So we can think about, is there an evidence-based treatment that matches that diagnosis? How do we make sure that what we are providing therapy for is really a match for the challenges that might be going on with the client that we have in front of us? Whether or not there's a specific diagnosis that matches with a treatment, we're also going to be thinking about that initial assessment in informing therapy goals, as well as maybe appropriate external referrals. So, for example, to think about medication with a psychiatrist, to think about, say, vocational rehab services, or if we have a child or young person thinking about special education services, what else might be available to this client that could supplement the therapy that they're having with us? as well as thinking about not just assessing for what are the mental health symptoms, but also trying to get a sense of things like communication needs, learning styles. Does the person like visual supports? What type of communication do they prefer? So we can think about those accommodations that we might make to therapy along the way. Um, I think oftentimes that sort of practical piece and the treatment planning is where a lot of therapists stop thinking about the role of assessment. But I would argue that that's actually missing something really important. Is that as somebody who does a lot of assessment, I really believe strongly that assessment itself can have a direct therapeutic benefit for a lot of clients in a number of ways. And that when done well and thoughtfully, that assessment can actually be a really powerful intervention in and of itself. Some of those are in relatively sort of simple ways, like rapport building, right? Your assessment is really your first opportunity to interact at length with a client who hopefully is going to stay with you. And the least effective therapy is the therapy that your client never comes back to. So if we don't build good rapport in those initial sessions where we're doing assessment, that client doesn't end up feeling like we've understood what's going on with them, what brings them to therapy, and what they need, they probably aren't going to show back up in therapy. Or even if they do show back up for a number of reasons, particularly in this population where it might be a caregiver or a parent or a sibling who's bringing them, that we're going to make much slower progress if we don't set off on a good foot with that really positive rapport with the client as well as with other significant people in their lives. So I think that when done well, that assessment can be not just checking off a box, but really that first opportunity to help that client feel like you've connected with them and you've understood what's happening with them and why they're here and what they need. Kind of along those lines, I think that good assessment has a really powerful potential to increase both self-understanding as well as others' understanding of the client in ways that may be really powerful therapeutically in and of themselves. I think this is true for any clients, but I think can be particularly true for clients with intellectual disabilities. As you all know, probably from participating in these, that many clients with intellectual disabilities have a high rate of having their mental health problems misunderstood, undiagnosed, misdiagnosed, and really not understood in a comprehensive way. And so, for example, if you have a client come in who maybe is experiencing depression that has come out as irritability and behavioral challenges for them, being able to help them understand that maybe depression is part of what's going on for them, may be a reframe that is super powerful for that person as well as the significant others in their life to think about, hey, this isn't that you're behaving badly or that we just need a behavior intervention or you just need to get it together. This is a mental health problem that is shared between many other people. And I think that knowledge, particularly for clients with intellectual disability, that mental health problems are common, that there are things we can do to treat them, and that they can be an explanation for a wide variety of things that might be going on that that person may not have a good understanding about themselves can be a really powerful place to start with an intervention if we're able to really get that understanding of the person. So I think that spending that time that's needed, even if for this population it's often more than just that initial intake session, really doing a good assessment, trying to get a deep understanding of what's going on with the person is absolutely worth the time. And I think it very much is the start of the therapy as opposed to feeling like we need to hurry up and finish this assessment so we can get on with the therapy. I want to spend a little bit of time too thinking about what are the sources of information we might think about for a comprehensive assessment, particularly for a client with an intellectual disability. Some of these are really similar to with any client, and some of them I think are uniquely important for clients with intellectual disability. So certainly interview is oftentimes a really important piece of an initial assessment. Of an interview with the client and potentially an interview with supporters or caregivers if that's something that the client is comfortable with and wants those people involved in their therapy. So thinking about that might be something that could happen together or might be something that in some cases happens separately, at least in part, with the client having an opportunity to kind of speak about their perspective and supporters or caregivers also having an opportunity to speak with their perspective. And I think really keeping in mind that the goal here isn't to decide who's right or wrong. It's to think about, hey, we have multiple perspectives on what's been going on here. How do we bring those together to best understand what's going on with this client and help them to ameliorate those challenges that they're having? Standardized checklists or questionnaires, I think, also can be a really nice part of an initial mental health assessment with a client with intellectual disability. I think this is a really common part of mental health assessment in clients without intellectual disability, but maybe overlooked in clients with intellectual disability because of perhaps the inaccessibility of the standard questionnaires that clinics use, or believing that the person may not be able to respond to those in the same way. And while it is true that oftentimes clients with intellectual disabilities may need some additional adaptations or thought given to the way that we use things like checklists or questionnaires, there's good evidence that many people with intellectual disabilities can provide useful information through questionnaires or checklists about mental health symptoms, and that can be a really nice complementary source of information. So we might think about checklists or questionnaires around mental health symptoms, either broad mental health symptoms, or if you maybe have a suspicion that, for example, there's depression or anxiety or trauma going on, more specialized questionnaires that focus in on those. I'm going to be talking in the next few slides about some recommendations for how to adapt those types of questionnaires for individuals. And definitely thinking about psychosocial indicators as well. Things like traumatic experiences, independence in things like daily living skills, communication abilities. These may be some things that are really useful to probe a little bit more in that initial assessment as you're designing what therapy is going to look like for this individual and thinking already about the adaptations that you may be making with the therapy. And finally, I want to give an important plug for record review here. I know that we all know that this is probably something that's ideal, is to be able to think about previous treatment or assessments that a client has had in any sort of situation. I think this may be particularly important for clients with intellectual disability. As a group, it's probably more likely that this group of individuals may have had contact with a number of different systems like school systems, mental health systems, developmental or other systems. And so a number of things may have been tried in those systems already. So you might be able to learn something about what interventions have been tried, what was maybe successful or not so successful, as well as some things about learning, communication, those sorts of things that can be really useful so that you're not reinventing the wheel with some of those types of assessments. Also, certainly thinking about previous mental health records if those exist and the client feels comfortable sharing them. And I think that's important to look at, and also to take chart diagnoses with a grain of salt in this population. We know that there is a really high rate of misdiagnosis and missed diagnoses of mental health problems within this clientele. So I certainly wouldn't assume that just because a diagnosis exists in somebody's chart that it is definitely correct, and that should replace an additional assessment. But it certainly might inform what they've been treated for in the past, things that we may want to look into in more detail. Just to give an example, I saw a young man quite a few years ago now who did not have an autism diagnosis formally, but I very, very highly suspect that that was an appropriate diagnosis for him, and had a mild intellectual disability and a history of a lot of disruptive behavior and contact with the police, and was sort of in therapy for working on sort of general emotion regulation and outbursts and those sorts of things that he was struggling with at that period of time. Um, the psychiatrist was convinced that he was actively psychotic, and I was very much not convinced. And, some of the things in the record, we're seeing this client at the same time. And some of the things in the record that were evidence for his psychosis was, for example, being cagey with eye contact and tending to look off in the corner of the room. And the psychiatrist was convinced that this was because he was seeing things up there. I think it's just because he didn't feel very comfortable with eye contact from my expertise with that population. Or, for example, he had a family member who had died and talked a lot about seeing her in the clouds. And that from our conversations about this seemed like a really kind of culturally appropriate belief about heaven, as opposed to him literally seeing things in the clouds, but the psychiatrist was not interpreting it through those lens. So just kind of as an example to think about, hey, we want to have those collaborations, we want to be thoughtful about those things, but not everything that appears in a mental health record should definitely be taken as absolute truth, particularly if some of the other providers that have seen the individual don't have expertise in developmental disabilities. So I think all of these things ideally should be a part of an initial mental health assessment to think about how we go forward. I want to say a little bit more about this piece around checklists and questionnaires because I know that's something that can be difficult to think about how do we do this effectively within this population. And what might be some of those adaptations that we can make to assessments, both the interview and those questionnaires, to make them most accessible and adaptable for individuals with intellectual disability. One thing to think about, and I know that we have talked about this in a number of other ECHO sessions, or will be if we haven't gotten there yet, is thinking about communication style and adjustment of communication style during interviews as well as ultimately during therapy. We always want to be avoiding jargon with our clients anyway, but I think that some words that may be very familiar to your average client without intellectual disability may be very jargony to our clients with intellectual disability. Or even kind of checking in about, all right, when we talk about depression or anxiety, what does that mean to you? Do you know what that means? Have you had experiences with people who experience depression or anxiety, for example? Uh, Oftentimes, when we're interviewing in an initial interview, we want to get a sense of timeline of events. So, for example, how long has the person been having low mood, or when did they start feeling anxious about a particular thing? Um, None of us are generally that great about anchoring events. We all have our own biases about how we think back in time, but this can be especially true for individuals with intellectual disability who may have a challenge thinking about how do we anchor those time-based events. So one thing that may be useful there is to help probe with the person about major life events that have been important to them. And it might be something as big as, moving to a new residence, or it might be something that's sort of a more daily occurrence, but that would stand out in their mind, like their last birthday party, or some other event that they've had that stood out for them. And so then rather than saying, okay, well, in the last month, how have you felt? To be like, all right, well, since your birthday party at Texas Roadhouse, do you remember how have you been feeling in this period of time? And that can be a really nice way to anchor some of these things to concrete events and make it easier for individuals with intellectual disability to report about time course. And I think the other thing is really to just take a non-judgmental style to that. Really encourage questions, lots of pauses, kind of checks for understanding, with the assumption that it's likely that there will be misunderstandings or questions. I think that one of the things that I've thought about over time with clients is that there's a really subtle but important difference between pausing and saying, okay, do you have any questions? And pausing and saying, wow, that was a lot of information. Let's take a moment. What questions do you have for me? That sort of difference between, do you have any questions? Which sometimes I think to people who are used to going through situations that they probably don't understand a lot of what's going on, that isn't for them because it hasn't been adapted for them, and that they feel like the right response is, nope, I'm fine, I don't have any questions, versus making it feel like the right response or the expected response is, hey, that was a lot. What questions do you have? How can we make sure that this is clear? Or even checking back in to make sure that the understanding that you've gotten from what they've said is correct, so that you can kind of give them an opportunity to correct them, to correct you if you haven't quite gotten it right. In thinking about questionnaires, I do think depending on the client, there may be some that questionnaires are more or less appropriate for, but many individuals with intellectual disability are going to be able to use adapted questionnaires or questionnaires that you help them with to provide some more standardized report about mental health or other symptoms. Um, One consideration is there are a number of adapted questionnaires designed for individuals with intellectual disability that are out there for reporting on mental health symptoms. I'll put a few of those up on the screen in a moment, and we certainly can provide some suggestions and lists of those, many of which are freely available online. So for constructs like depression, anxiety, trauma symptoms, there are many questionnaires that have been adapted by research teams for this population. If you don't have something that's a good match, or even if you do and you think additional adaptations are needed, to think about things like, are there multiple methods that the person could respond that I could give them a choice between? Would they prefer for me to read the questions aloud to them and we talk about the answers together and circle them? Or would they prefer to try reading them themselves first? That's really going to depend on the person. Some people, if they have the reading skills to read them aloud, it may be good to still kind of stay next to them and just let them know you can read it on your own if you want to. If you get to any words you need help with, or there's questions that are confusing, just let me know and I can clarify for you. There may be other people where reading it aloud is going to work much better for them. For people who are reading the questionnaires on their own, thinking about things like layout and format, I've noticed that oftentimes the priority for layout and format of questionnaires to make them easy to understand often prioritizes fitting everything on one page, more than thinking about font and breaks and those sorts of things that may make it easier to read and process information. So it may be that you have a questionnaire that you think is going to be appropriate for somebody, but it's all squished into tiny font on one page. And thinking about, can we copy this in a way that we can make the questions larger? We know that many people with intellectual disability prefer larger print. Can we break it out into fewer questions on one page, for example? So some of those simple things that may just make it easier to process information. And then thinking about things like the language. Might they need examples or clarifying prompts for words that are in there that they may not understand? I'll say, having gone through questionnaires with a lot of parents or gotten responses that weren't what I expected and then gone back, a lot of questionnaires need some clarifying prompts or examples, even for people who don't have intellectual disability. I'm not sure our questionnaire writers always do the best job at communicating in a way that is clear. This may be particularly true for this population. And thinking about response choices. We know that many people with intellectual disability have communicated that our sort of typical like 5 or 7 point responses feel really hard because that's a lot of choices. So thinking about, might we be able to reduce the number of response choices to still get some good information? Or even, for example, if you're going through it in an interview format, to start by asking the question as a yes or no, and then expanding to how often if they get an affirmative answer. So, in the last 2 weeks, have you been feeling sad? At least some of the time. And if they say yes, okay, well, is it more like half the time or almost all the time? And thinking about where we end up on that scale. And I don't think that we want to assume that we have to make all of these adaptations up front, because there may be some adults in this population who can use questionnaires in the formats that they're currently described. But just kind of thinking about what's working for them, trying some of it up front, understanding what those adaptations are. And rather than, if I hand them a questionnaire and they're not able to do it initially, to assume we should just throw this out, to think about what are some adaptations I can make so I can get some information in this way from the person, even if they're not able to do it in a way that is as standardized as you might be able to give me, a T-score off of this measure. Just to kind of put up a few examples of things that are out there in terms of questionnaire assessment tools that are designed for individuals with intellectual disabilities. There's a group in the UK that has developed 2 scales for anxiety and for depression, specifically meant for people with intellectual disabilities. They have some visual supplementation, some additional prompts for clarification, as well as suggestions about how to present the information, like with anchoring to life events for the scales. A couple of ones that are more general, that might be used as kind of psychotherapy outcome tools that go across different areas include the Core LD and the PTOS ID, that are both designed for people with intellectual disability to go across a range of mental health symptoms. And then this is one that specifically focuses on trauma. We know that is a really common experience, unfortunately, for people with intellectual disabilities. This trauma information form actually goes through and describes particular common traumatic events in really clear language that indicates exactly what it is, and asks the person whether they've experienced that after describing it in clear language and with some additional graphics. And then the trauma questionnaire for intellectual disabilities is sort of a follow-up that once you have an idea what traumatic events the person may have experienced, you can probe about PTSD-related symptoms that could be related to those events. So they really can kind of go together. I want to wrap up by talking a little bit about how I see assessment and therapy relating to one another. And sort of what that process might look like of moving from that initial assessment into psychotherapy with a client with intellectual disability. So if we talked about that initial assessment that may take a few sessions, should really encourage you all to work together to understand diagnoses as well as strengths, needs, preferences of the individual to really be able to go into that with a solid relationship and enhance the person's understanding of what's going on with them and the challenges they may be having. And so that should really end with sharing the results with the client with the goal of increasing self-understanding as well as scaffolding goal setting. I wouldn't want a client with ID to ever come out of an assessment that, they did an initial session and now it's time for therapy and nobody ever talked with them about what the findings were from that assessment or what they mean. Or, you ask me all those questions and then now what? And I think that that could really lead to a lot of misunderstanding. So I think taking the time to go over those results, talk with them about how you understood all of the information they gave to you, what you think that means, what suggestions you would make based on it, and also be working with them as well as any support people who are involved in therapy to think about what does the result of that initial assessment mean for the goals that you might move forward with in therapy together. I think it can serve as a really nice bridge in order to start therapy, for moving from that assessment into therapy with that collaborative goal setting. So really thinking about that opportunity that's brought in by that assessment feedback for collaborative goal setting to happen to really serve as a nice bridge between that assessment and the initiation of therapy. So then you're moving in together with a shared understanding of what it is you're trying to accomplish together, what might be some of those mental health conditions that are underlying some of the challenges they're having, and making sure that everybody's on the same page about how to move forward. And finally, I want to make sure that we don't stop with assessment there once we've initiated therapy. To remember, just as is good practice with any client, that thinking about that continued regular assessment and progress monitoring as needed to continue to see where are we at, what goals have we maybe accomplished, what things might we need to make tweaks to make sure that we're moving forward, or are there new things that have come up in the person's life that might make us change direction a little bit with the therapy that we're doing. I think that thinking about that progress monitoring, we do want to be thoughtful about the time and effort that some of these assessments may take for adults with intellectual disability. I know it's sort of common practice in many psychotherapy practices, for example, that, oh, you'll do a little, 30-item questionnaire about how things are going while you sit in the waiting room before every session. That may be not particularly feasible for every session for a client with intellectual disability if it's taking more time and adaptation to maybe do that in an interview format, or just the cognitive load that might be associated with doing those sorts of questionnaires. That may not be the case for every person, but so I think that really tailoring that to the individual, how much adaptation that they're needing, and what may be the best ways to think about assessing that. But to make sure that there are some planned regular assessments of progress, both on goals as well as any kind of key mental health symptoms that you think are important as you go along so that you can continue making those tweaks over time as needed. So I am going to leave it there. Thank you to our RRTC grant and team that was really involved in a lot of this work and some of the systematic reviews and other pieces that we did to provide this information. And I'm excited to take any questions and have a chance to hang around with all of you for the case study portion.
Wonderful. Thank you so much, Dr. Walton. I'd like to open it up to questions. Christine, I see your hand raised.
There's something I just wanted to point out, even though this something for all of you to know that's going on in the state, okay? And it has to do with mental health screenings, okay? They're doing dementia screenings now, and I'm gonna be honest and tell you guys this, and it's really true, okay? They try to say something like, have you had a decline in your handling your money? Well, something I've told people is an 18-year-old is not a genius handling their money like somebody in their 40s or 50s, okay? You can't say because they're 18 they they actually have dementia. You know, so point is this, don't go always by the assessment sheet because sometimes they don't think of everything. People, when they're 18 with IDD, might have a payee So they've not had any experience handling their own money. So how can you say they have a decline? Okay. I wanted to point that out for people so they know what we're fighting against, because I just feel it's wrong that they try to say an 18-year-old has a decline in money, that they have dementia. Sorry.
Yeah, Christine, I think a couple of important points there around assessment. One is that, and again, I didn't mention dementia, but we know that dementia is an increased risk for many people with disabilities, particularly Down syndrome by middle
Yeah.
age is associated with risk for dementia. So I think that's something to be certainly screening for in a good mental health assessment if we've seen a change in
Well,
functioning over
they're
time.
now they're
But that
now
also
testing.
but also that we need to be having well-adapted tools that are appropriate for the life situations of people with DD when we're thinking about those. And we can't just assume that the same tools that we're using for people without intellectual disability are always going to be the ones that are most appropriate to the life situations of people who have intellectual disability. I think those are great
Yeah,
points to
well, the
remember.
thing is, the state has now mandated that anyone 18 and older with ID has to be screened for dementia. I'm like, you say an 18-year-old who doesn't know how to handle their money hasn't learned how to handle it, okay, says they have dementia. So what we have to be aware of is this. If the person has not even learned how to do the thing, how do you say that's a decline? Okay, there's no decline. It is the person hasn't been able to learn how to do the item. So you just say same way they've been, because if somebody has a payee, for instance, that's a whole other thing. Now, if one day somebody went from being able to handle their own money, handling all their finances and stuff, and then one day later got dementia, can't know where to do, how to handle money, and then somebody's being the payee, let's say that, then that's different to say, yeah, they've started to get dementia. But you can't put an 18-year-old to say, oh, because you can't handle your finances, you have dementia. I don't agree on that. And my friend Jean Stunts, who's a natural support, she totally agrees with me. That's silly to say you have dementia. Uh,
Thanks,
Patrick?
Christine. I'm sorry to cut you off. I see Patrick has his hand raised and wants to jump in. Patrick.
Yeah, can you hear me?
Yes.
Okay. I just wanted to piggyback on what Christine had mentioned. I think a broader point that she's discussing is that what I find with some of the folks that I get referred, they might have pays, they may not have a voice, and they may not be used to sort of completing assessments without someone prompting them or without reflexively answering in ways they think I want them to answer. So often I will do some relationship work as I get to know an individual before I start doing some of the other assessments. Or I'll adapt assessments to include sort of um, sort of interest inventories that I'll then sandwich questions in there that will address mental health. So I might talk a lot about what kind of music you like, but then within that same assessment, I'll add what are some things that get you upset recently, or do you ever get sad about stuff? So I'm trying to sort of get to know folks and make them feel comfortable at the same time starting to pull that out. And I will do assessments ongoing as I get to know a client. So I think that some of what Christine said was, when you have folks who come in who have never had a chance to be a payee or do their own finances, how can we expect them to answer these assessment questions?
Yeah,
Yeah,
I think
I
that's a
agree, because my biggest point is this, okay? There shouldn't be a wrongful answer saying, well, you've never handled your money, so you're incompetent. It's like, well, I've never been taught. How do you suspect me to? If that was the person who was 17, even somebody normal without any IDD, and even a 30-year-old without DD, they're not perfect in handling their money 100%. No one is. But you can't say, well, you can't handle your money, so you're incompetent in your finances. Sorry. Had to.
Great. Thanks, Christine. Yeah, we had a couple comments in the chat as well. Chelsea had mentioned something about establishing a baseline prior to making an assessment of decline, followed by Ranju mentioning completing and periodically repeating adaptive behavior scales may help. Justin asks a question, any good quick tips on measuring therapeutic goals throughout the process?
A great question, Justin. And I think it probably depends on what the goals are. But one thing I would say is uh, trying to tease apart frequency and severity of challenges that people are having. I found that it's really common when you ask somebody, well, how have things been going this past week? And let's say it's somebody who had been having almost daily significant challenges with whatever the issue was that they were having, right? And maybe we're now only having those challenges twice a week, but the day before they came in, wow, was there a big incident? That will be so salient in people's minds that they'll say, well, it's just been terrible and tell you all about this incident that happened yesterday. So I think sometimes having some plans to track both, the significance and the impact of challenges that people may be having, as well as how frequent those are happening, is a really important piece because I think that it can be really easy to have those things get confounded in people's minds. And then to miss that progress is in fact being made, and also miss opportunities to say, wow, I know this incident yesterday was really significant and I want to make sure we talk about this, but wow, we only had two things come up this week. So there must have been other things, let's say irritability is a problem. There must have been other things that got on your nerves this week. Like, what did you do to not have it blow up into that? What are we doing right? And all those other moments that we can apply to maybe these other two incidents that you did have this week. So I think that sometimes I think tracking of kind of particular challenges that the person is having that are most impactful is one piece. And then I think that enables you to still use some of these maybe more standardized scales, like behavior scales or anxiety scales, but perhaps a little bit less frequently, just because of the burden and because we might expect changes on those standardized scales to be happening a little bit more slowly. So I think kind of a balance between individualized goal tracking and hopefully use of some standardized scales, if that's something that's appropriate for the person, is oftentimes a good balance.
Thank you. I know
Thank you.
Patrick had
That's really
mentioned
helpful.
oh, so yeah, sorry to cut you off. Patrick had mentioned a specific tool here in the chat as an acronym. Would you mind spelling that out for us, please? Looks like he's going to spell that out for us in the chat. Maybe just a quick lightning round. Really want to thank you again, Dr. Walton, for your time. And, interestingly, I think you're coming a lot more from a background of serving younger populations, right? As the director of our early learning program. I'm curious about, again, just quick tips on how we can utilize assessments and tools that are meant for a younger population, but do it in a dignified way that supports not infantilizing, but is age appropriate for this population. Is that a good place to start for adapting and modifying tools, or any final thoughts on effective approaches to assessing this population before we move on?
Yeah, I do think that we can think about this from either or both directions, both in taking tools that were initially designed for non-disabled adults and thinking about how do we modify those, and also thinking about tools that may have been originally designed for children and up modifying them. I think that figuring out for any given situation what's our best direction to go is really helpful because I think that it's just going to depend on the tool and the situation. That I think there are times I think things that tools for adults are oftentimes lacking in is that the language is too complex. Sometimes the concepts and the assumptions about responsibility are different than the lives of the individuals we're assessing. The sort of roles of caregivers in their lives are different. And so I think those are things that we need to be thinking about, as well as things like vocabulary and response options. So I think when we look at tools for kids, oftentimes the vocabulary and the response options are much closer to what we need for our population of adults with ID. But I think we need to be thoughtful about the setting and assumptions about who is sort of responsible for behavior and choices, because oftentimes they are talking much more about, following directions from parents or things happening in school settings, or with peers at school. And so I think sometimes that content ends up needing some modification in order to make sure that they're appropriate for the social settings and situations that the person is in. So I think coming from either direction can be appropriate as long as we're thinking about what are those things that need modification to make sure that they are going to be appropriate for this population.
That makes sense. Great answer. And Patrick also updated, and this is a fun one. The Achenbach system of empirically based assessment was the tool that he had mentioned. And it also had his hand raised. A final thought here, Patrick, before we move?
I can't remember what it was that Dr. Walton mentioned or said that triggered something that I have to keep when I'm assessing folks, especially our folks who have these big teams or may still have guardians. The guardians and the team may be telling me that there's a certain mental health need that the client is like, no, that's not my need at all. Or they have a different, when an individual with the ID or DD just sort of takes a stand, sometimes that's interpreted as not being cooperative or being confrontational when they're sort of finding their voice. So when I do assessments, I'm also at times trying to make sure that the team understands what they think is the need is not necessarily the need, if that makes sense.
Mhm. Right. The problem is that every time we take this person to bowling on Thursdays, that they pitch a fit. And from the person's perspective, they're like, I don't like bowling. I don't want to go. Why is this a problem for everyone?
And they end up saying, yeah, we need you to go see a counselor when it's really, you just need to pay attention to what someone likes. Yeah.
Yeah, I
So-
think that's a great place to end this this great conversation. Again, tying it all back around to the dignity and the individualized approach of working with yet another unique person. So thank you so much for the presentation, Dr. Walton, for the engagement from the community. At this time, we're going to transition into our case. And